Ladies and gentlemen, welcome back to an all-new episode of The Bearded Biomed. I am your host, Chase. And today I am joined with, you know her, you love her, Danielle from AAMI. Welcome back to the show. It's been over a year since you've been on before, but now you're an official friend of the show, so glad to have you.
I'm so glad to be back. I always love being on your show, and I love watching your podcast. So thanks for having me again.
A lot of changes since then, but yeah, we are joined by Danielle today because we had something very interesting that AAMI put out to the masses that I think is more beneficial than probably a lot of people understand or just haven't really dove into the information of what this collection of data proposes. So what am I speaking of? I'm talking about the HTM Grey Areas report. Before we get into the nitty gritty of the details, what spawned this whole endeavor that you guys took on for this, project?
Sure. So everything that we do at AAMI really comes from feedback from the field at large. So, anyone that's listening, please don't ever hesitate to email me directly or email people on the Technology Management Council or Healthcare Technology Leadership Committee with suggestions. Our TMC group last year, we take on about 3 to 4 projects a year. And one of the suggestions was, the unclarity of gray areas within, between medical equipment and what HTM should be supporting and what really isn't considered a medical device. So that whole project came from their suggestion, and we made a subgroup that was led by Mike Bustiger, who's now the Technology Management Council chair. And we had a committee of folks on there, and we worked together. We sent out a survey to the field at large. We got about 120 health systems to respond to it. And we helped identify gray area, equipment that can be classified as kind of a gray area in hospitals. And we had folks, vote or let us know whether HTM was servicing it, facilities, IT, or someone else.
Well, I was looking through it, and a lot of it speaks to my soul because
that was what we were going for. We wanted to hit deep with this project.
I think a lot of biomeds out there will have experienced some spectrum of, the gray areas of medical device, whether it's responsibility, what's expected to be inspected, electrical safety checked, or just inventoried by the biomed. I mean, there's a lot of data here, which makes sense to me. And what's interesting about it, for those of you that have not seen the report, it's not just broken up just, based upon equipment in biomed. Y'all went so far as responsibility percentages based upon facilities, security, IT, and even that other space. Because let's be fair, there's some overlap in some things, which is what causes gray area as well. Most of the time it's biomed and facilities sometimes, but it can also be biomed and IT, especially today with the integration of medical device telemetry. Everything's hooked up via Bluetooth, Wi-Fi. What was something that I guess was your first takeaway after y'all compiled this data together?
I think the first takeaway was that, there's definitely not consistency across the board, right? And
Don't say.
No matter where you go, I think it's interesting because I think we become myopic as biomeds at time. It's like we're used to doing it how we do it at our medical center, right? And everyone thinks that they're doing it the right way, which you may or may not be. So, some people are really proud maybe that they're, taking on security cameras, but is that the right decision for the field? So I think instead what our takeaway was that we didn't want to be prescriptive about, what HTM or biomed department should be doing, but we wanted to give concrete data so HTM and biomed departments could make good decisions. They now have a report to go back to their C-suite or whoever they report to and say, look, this is what the majority are doing, and we either should or shouldn't be servicing these as well.
Well, we have to look at it too as out of all those hospital systems that you guys surveyed, I guarantee none are alike. Every hospital does something a little bit different, just based upon their staffing, their budgetary, their whatever their accrediting agency may be, whatever professionals are running the C-suite, just management in general, because everybody's gonna work and fluctuate based upon their prior experiences and well, we used to do this way, and that's why this report is so informative. um I mean, you can have just an example. um I remember the old adage was, if it's inside the wall, biomed typically doesn't work on it. That's not always been the case, because med gas can translate into biomed, limbs can translate into biomed. I've seen some like anesthesia, supply lines that go into the wall have had some biomed maintenance. Either there's a lot of different things that can translate, and
Exactly. Especially with beds too. Like I know we
yes,
used to service the low
uh,
voltage relay that went from the TV to the pillow speaker, like, and that's in the ceiling, so it does really vary. And
probably one of the most arguable ones I think would probably be the nurse call systems.
yes, yes.
And more often than not, you kind of have to share that responsibility, with troubleshooting what's actually the cause. Is it an actual PCB board inside the bed communicating with nurse call? Is it the cord, or is it the actual nurse call system hooked up into the wall? And more often than not, you have to coordinate with facilities to do that testing all together. I like your verbiage that you said this is not a prescription, because we don't want to get into make this a thing that you can take to a C-suite and make it almost argumentative. It's just more just providing the data based upon the medical landscape. Hey, this is how it's being done. Because
Exactly.
if we came across it as confrontational with, this is how it is and this is the only way it shall be, well, it's going to be more often not having issues implementing, what we're seeing in the survey.
Exactly. And we didn't want to do that. We don't want to say like you have to be doing beds or you have to be doing nurse call. We just really wanted, people don't know what they don't know, and they may be wondering, well, what do my peers do? And this really gives you comprehensive information to really understand, because we also sorted it by percentage. So HTM at the highest, then it works its way down to the lowest percentage as well. So hopefully, HTM departments can find it useful. And also, like you were saying, like no two HTM departments are the same. It's really going to depend, like, if you're a critical access hospital and you're a one person show versus, these large health
Yes.
systems that, have 100 people, they can have a biomed IT team within their HTM team, but that's not the reality everywhere. And, if and this is really just to help.
Well, there's especially in Texas, there's a lot of critical, rural hospitals, LTACs that just don't have the staffing to, like you alluded to, all these different responsibilities broken up. Usually, when I go into those sites or our company goes in and provides for them or assists maybe a one-man shop, they're taking it all on just because they don't have the bandwidth to separate all these responsibilities. And with the percentage breakdown of what you guys have too, you don't even have to tailor it as saying it's a responsibility breakdown. I would almost format the speaking it into existence as, look at the percentages, and this is the percentage of each department that should be involved in that project.
And that's a great way to look at it too, because, as we know, everything in a hospital is a multidisciplinary approach. Like even telemetry center, your telemetry units. I mean, it goes back to a switch in the closet somewhere, and if that switch is down, you may need an IT person to help you. It all goes back. So
I mean, I still lean back to, there was a service call, it was a couple years ago that I had. It was in critical access hospital, rural middle of nowhere in Texas, and it was at like 2 a.m, and all of their telemetry system went down. They were unable to monitor any of their patients, and they called us in, of course, because you got to call the biomed for something like that. And I traced the problem all the way to a IT tower that was locked in a closet that, of course, I had no access to, no security keys, no nothing. And the IT tower actually belonged to a prior company that no longer was in that hospital. And we still brought the other IT department in that is now in there because they had the best chance of getting us to help reboot the system. And again, if we go into the mindset of it's just one person or one department's responsibility to do something, that's usually going to lead to more downtime for equipment and making it inaccessible for the end users, the clinicians, and also this reflects back to towards the patient as well, of not guaranteeing that higher level of healthcare that we want to provide. So it was a joint venture, which I think is, to me, what solidifies the survey is it shows that there is a need for cooperation between all the departments.
Yes, and to also have, and at the end of the document, it talks about best practices and having almost a responsibility agreement that, like, if we decide we're handling, a certain part of a system, that's clear throughout all the departments that could be involved. So that way, on a weekend or when you get called in on Christmas morning, God forbid, we're not making like 30 phone calls. We know, who is that next person of escalation? Or, I've exhausted troubleshooting this monitoring problem and it looks like it's, back to an IT issue or the Wi-Fi's out, for the host, in just having people understand because, sometimes I used to cover Muse at an old hospital, and, I could bounce the interfaces on my side, no problem, but sometimes the interface from the EHR would be down. And the minute someone said Muse on the phone, it'd be like, that's Danielle, that's Danielle. But like once you troubleshot it, you might have needed the EHR team to come in
Right.
and help. And those are things, if we can agree like where the responsibility is that I get first call, I troubleshoot it to, as far as I can. But once I've determined that it's something outside of that system, now we need folks to understand. I'll never forget, I had called back the help desk with an update with a Muse problem once, explaining to them that I needed someone from the EHR team, and they said, "You're gonna have to call Danielle Mcgeary." And I said, "I am Danielle Mcgeary. I'm calling you for help, and we need this escalated elsewhere." So,
The one of the things that can bug me when I look back at just interactions that I've had with biomeds across the landscape, either those that have been, in the field for as long or longer than me, or even some of the newer technicians. One of the verbiages that I hear sometimes that can kind of annoy me as a biomed is that, well, that doesn't fall under my area of responsibility, or that's something that I'm not in charge of taking care of. And I think this is also beneficial for that to reacclimate the landscape of our career field and say, okay, again, we understand that not every facility is going to be the same. We understand that areas of responsibilities, depending on the type of equipment and what they're asking you to do, might differ. But I would encourage the field to look at this report and take it almost as a recalibration almost of what your expectations for your daily job should be. If there's an issue that per se I've came across and I don't necessarily have had the responsibility or the expectations on me to take care of it, but it's something that I feel I could assist with, I'm going to do it because at the end of the day, that's what we're there for. We're there to get the equipment up and running as quickly as possible and make sure that it's ready for patient use and in a safe way. And if it's something that falls within this gray area, well, this is a call to arms almost. I would say for, maybe some of you out there that don't really have the expectations to have worked on some of this stuff before, to maybe just go about it a little bit more, go with the flow wise. Just, realize that there are areas of responsibilities that can fall on the biomed that maybe you haven't experienced before.
absolutely. And I think it shows that, really, if you look at it, for most areas, there was never like a 0% HTM,
Mm-hmm.
I mean, so it wasn't, so, I mean, it shows that, anyone can really be doing anything too. So I think that was really telling as well. So
Well, look at it this way too. If something, God forbid, happens to a patient, who's one of the number one departments get drawn into anything? If it was something that was used to treat a patient, it's the biomed department.
mhm.
So whether you like it or not, whether you worked on it or not, you might get pulled into that discussion just because of what our job entails. And the thing I want to carry over to is after the survey, or I think what I want to allude to is I would assume there was some amount of Joint Commission, maybe DMV interaction with AAMI of going through the chronicles of this report. So I'm kind of
Yes.
curious about how that went and maybe some of the intricacies of that conversation.
Absolutely. And thanks for bringing that up because that's a big part of this. So we did work with Herman McKenzie from the Joint Commission. And one of the things that we did learn is the Joint Commission, and I actually didn't realize this, they're really big on having a policy and following your policy. So I knew that part. So if you have a policy written and they come in and ask for your policy and find that you're not following your policy, you're going to get cited, right?
Do what you say what you do.
Do what you do. Exactly. But they actually, because they are auditors, they are not allowed to write policy for a biomed or HTM department. So if you came to them and said, "Oh, can you help me write my MEMP?" They can't do that. That's not within their jurisdiction. Okay. So while they vetted this policy, they couldn't, say every HTM department needs to adopt this policy because, like we said, you can't treat all hospitals the same, and the Joint Commission clearly knows that. And, going back to our earlier discussion. So Herman McKenzie went through and looked at it, and he helped us, though, define what in that list is medical equipment and what is something else. So he made the fabulous point that just because HTM/biomed is servicing something or it's in your responsibility, it doesn't mean that it's technically medical equipment and that it has to fall into your MEMP. So he said it's very important to go back and look at everything you're servicing. So let's say you're in charge, your biomed department is in charge of microwaves. That is clearly an appliance, not a medical device.
We still electrical safety test them.
But, if you have defined it in the Joint Commission eyes as an appliance, it does not need a yearly check. So so he's saying that you need to, just because you service it doesn't mean it's medical equipment. It doesn't mean, because with medical equipment, they want you to follow manufacturer's recommendations. But if you're not defining something as a medical device, now that does not apply.
And again, that definition is based off the facility's policies and procedures.
Yes, and he said you should go back and redefine that. But again, that if you're currently calling a microwave a medical device, again, you need to follow your written policy. So if you're going to change that, you can, but it needs to go back through your EOC, and then you can get it approved. So you can't, and the same thing with this whole paper. I just want to be clear that if you look at this and say, "Hey, I've been servicing this widget for years, and the paper says that most HTM departments don't," you still need to go back and get approval and change your policy. Don't just start changing your policy without without getting approval from your EOC.
Yeah, because there's facilities out there that we tag this patient nutrition refrigerators, microwaves, coffee pots, TVs, exactly, Pyxis. And usually the verbiage that I guess this would entail back to the facility is if it's patient accessible, then it needs to be electrical safety tested and tagged. So it seems like some of the gripes I have, I need to talk to some of these facilities.
Yeah,
this is good information to know.
So when you go through that list, everything that was a gray area, Herman went through with me and helped define. So whether it's an appliance, whether it's like an HVAC or something, something that's
nurse cart. crash cart.
Furniture.
Yeah.
Yeah, so he's gone through. So, I mean, if you are servicing any of this stuff that's a gray area, you can at least go back through and see, okay, this should or shouldn't be called a medical device and potentially make a change if you get the buy-in from your medical center.
I feel like I need to have Herman on this show and just talk about a lot of things I've experienced because I've heard so many just from what you're conveying is the guy's just a plethora of knowledge
He
that
is. He's
I
excellent.
want to share. Um, so you guys did the survey, multiple facilities. You had Joint Commission come in and Herman vet through what his opinion on things. What else was entailed in the process, and then where do you foresee this going in the future now that this gray area report is out?
Yeah, so, it was vetted by Herman. He was very gracious to look through it. Herman is an AAMI board member and he's a great friend of Amy's. So, we love working with him and he's very gracious with his time helping us out. Um, and for the future, obviously the field is continually changing. And because of that, so will our responsibilities. So our goal is every 5 years or so, maybe redo this survey and see how it's changed. Back beds are a great example, right? Back in the day, they were standalone. Now they're networked. They do patient waits. They speak 30
They have so
languages.
many different
Go
things
back to
built
the
into them
EHR.
now.
Yeah,
Yeah.
exactly. So, now there's a stronger argument that we should be doing beds because they are more of a medical device than they were like a piece of furniture years ago. And, with this advent of home health, telehealth, and, wearables, I mean, we're going to see a lot of stuff changing. And, that may change, what we service in the future and even our jobs. So, I think it's important that we continually survey the field, see where we're at, baseline it, and continue to provide this resource back to the field so, people have that data and they can stay current and at least just know what their peers are doing.
There's something on here that I'm loving the percentage I'm seeing right now, and it's wheelchairs.
Uh,
I've had to fix so many wheelchairs in my life. It's not even funny. You raise a good point with the home health aspect because more and more devices are getting implemented for home care. And I think that's going to be an interesting next step for our field and just understanding the scope of caring for those devices and managing them because there's so many more home health care, urgent care, everything that's popping up everywhere, especially with the implementation of telemedicine. How is the biomed going to navigate that field? So I could definitely see the survey transitioning as you move forward. So that is good to hear that it's going to update with time.
Yeah, and it's really interesting when you talk about home health and telehealth because, like we talked about, our jobs used to be nothing in the wall, nothing in the patient, everything from the wall to the patient. And our primary customer was the clinician or the person on the floor that you're dealing with when the equipment's not working. If we end up with hospital at home, these medical devices or dialysis machines in people's
Yes.
homes or running an ICU out of someone's bedroom, now our customer has changed because we're going into homes and now we're talking to
Yep.
patients, so it's really interesting to think what could be and what could come of all of this.
Well, a couple of the clients that we have, for instance, dialysis, it's not just dialysis equipment. Patient lifts. I've gone into a person's home, set up their patient lift, calibrated their scale in their living room on the lift, showed them how to use it, and we go out there once a year and check it and verify it if they're still using it. So this is definitely a wave of the future. So, I mean, it's going to be interesting to see how that all falls.
Exactly. I'm really excited. I think the future is bright for sure, and I think there's a lot of change, a lot of
Job
excitement,
security.
and we definitely want to stay at the forefront of it and help the field as much as possible with valuable information. So,
Well, this is one of those things where it's better to be proactive than reactive.
exactly.
So, of course, Amy does so much more than just biomed, but the fact that y'all guys took this project on and really kind of delineated the areas of responsibility, I'm not the only one excited about this. I'm sure many people can seek benefit from this. So we want to let people know where to find this report. So what's the way to go about getting it?
Yeah, so if you go to the AAMI store and type in Gray Areas, it's free to all AAMI members, and I believe it's $30 if you're not a member.
I mean, that's affordable to possibly save yourself some work, maybe get some more work. Who knows?
Exactly. Yes. And all of our documents for HTM are free to our members. We want to do that for our members. We know a lot of you have individual memberships, and so if you're considering like being an AAMI member, it's $100 for the bronze membership. So even if you buy 3 documents or need to maintain your certification, the membership
Paid for itself right there.
Yeah. So yeah, but and if anyone has any questions, you can always reach out to me. I have a direct email, or you can just email htm@aami.org. We're always happy to answer questions, and we're always looking for volunteers. So,
but y'all are in that window right now for the TMC Council, and when is the due date for those?
It closed. We've already made our selections, but
Gotcha.
we typically do that in the spring. And you do have to be an AAMI member to apply and be selected. That is a requirement.
Well, there's always something exciting happening in the AAMI. Of course, we got the AAMI Exchange coming up in June.
In Long Beach, yep.
I won't be there because I'll be having my kid. And of course, I know you're expecting yours soon. So it's going to be I'm going to be sad I won't be there, but that's okay. We'll get the next one.
Absolutely. It'll be in Phoenix next year.
Oh, okay. That should be fun.
Yeah, absolutely.
Before I let you go today, I want to thank you and AAMI, and of course the council and Herman and everybody that played a part in this, because this isn't just something that's an overnight process. It's a lot of just going through communication, trial, error, working together, and collaborating. So it's things like this that really help enrich the biomed field. So thank everybody that played a part in it for providing this. I think it's really cool, and I'm going to do my part in just promoting it and letting people know it's out there.
Well, thank you. And I also want to thank everyone that took the time to take our survey. The field's feedback is so important. So when we put these surveys out, please don't be shy. Please, respond and give us your feedback, because this is how we're able to make documents like this. And Chase, I want to sincerely thank you for being such an advocate for the field. Your show's amazing, and being a supporter of AAMI. We love working with you. So I look forward to seeing you in person soon, hopefully, and good luck with your upcoming baby.
I appreciate it. We'll do a lot more in the future, of course. For anybody that is listening to the show, either Spotify, Apple, wherever you may be taking in your podcast, if you would be so kind as to either leave a review, like, subscribe. Spotify actually has a Q&A section now. So if you have any questions about the show or just want to leave comments, you can do that on Spotify now. Of course, if you're watching on YouTube, like, subscribe, leave a comment, continue the conversation. Let's keep this going, folks. So Danielle, thank you as always for being on. I always love just talking biomed with you, and appreciate you being on today.
Thank you. Thanks for having me.
May the beard be with you.
Bearded. Biomed.